I am here today to talk to you about delivering the right care at the right time by employing excellent standards and utilization review. So at Trinity Health, we are quite a large system. We have hospitals across the country in 22 different states. And as Julie was talking about standardization this morning, I'm thinking, yes, wouldn't we love it? And making many efforts to try and do that in many different ways. And I focus on the care management area of that. So I'm going to talk to you today about some of the things that we have done. So I did a little old school, and I put the objectives here that we're going to talk about. So we are working on assessing patients in the ED, understanding that we put them in the appropriate level of care from the emergency room, and how to be more efficient in our care coordination and treatment processes for patients that are in observation status. How many of you do not have a problem with observation patients? Yes, so I think that we all have difficulties in this arena in making sure that we're doing things correctly and getting patients in the right level. So as I begin to start, why did we want to do utilization review excellence standards? So through our organization, our executive leadership team approached us and had identified some issues that we were having. And so does anybody get everybody in the right level of care the first time? Consistently? Okay. Does anybody have the process of putting in the right level of care so that we don't receive denials from the payers? And being able to that. I know that as the previous speakers just said, in partnering with health plans, yes, we are trying to do that. Yes, we're trying to work together. But we still have what I would say way too many operational write-offs, way too many patients in observation for way too long, and in trying to do that. So in trying to find out if we have the appropriate patients in this level of care, in looking at that, you really have to start diving down and looking at case by case to see what's happening and what we're doing. So our leadership team wanted to know, so all these operational write-offs, is this really just a part of business, or is this something that we can fix? Is there something that we could do better? And as we've heard all yesterday afternoon and this morning, look at all the great things that are happening out there that are happening with our social determinants of health and the healthcare systems who are trying to fund some of this stuff. Well, boy, if we got paid for the care that we provided on the inpatient side consistently, wouldn't we have a little bit more money to pay for those things that, yes, cheerleading, right? Absolutely. If we could just get paid for that care, then we would have more money to be able to help with all of those social issues that we see that are extremely beneficial in helping our patients to be able to do that. So I think that those are some of the things that they were looking at in doing that. So could we, and so they asked, can we standardize utilization review across our system? So I will tell you, I work with probably about 50 acute care hospitals. And so, and we are in different regions, and I'll tell you, it's not consistent and it's not standardized. So we're trying this. We're trying to get there and being able to do that. So this is what we were charged for. And who's the accountable executive for the utilization review standards? So I work in the care management world, and everybody wants to point the finger at care management, right? Oh, those care managers, those care coordinators, it's them. Well, we had the privilege of not making them the accountable executive, but their boss, so that we could get people from the C-suite involved and engaged in the process to be able to do this. So yes, care management does do a lot of this work, but we need the rest of the leadership team to help and support, because it's not just care management who is doing this. So our care management leaders report to mostly the CMO or the CNO, and it's not consistent one or the other. We have a few that report to somebody else, but we are trying to get that consistency to be able to do that. So with these questions, we were asked, okay, so what can you do to help us? How can we decrease write-offs? How can we put the patients in the right level of care the first time? How do we know our observations volumes are right, and what can we do? So we worked together with a a team. So I'll say, as those people who are black belt in Six Sigma and all those good things, that we've done this before. And all of us in our organizations at some level have done these things. But I think we fell apart at the sustain part, or actually getting all the way there and then sustaining it. So I think that utilization review is not something that is new. It's something we've been doing for a few decades now, and that we just aren't doing it as efficiently as we can. So we looked at what we had already previously implemented, and I will tell you, at Trinity Health, they had implemented what we call the Proper Patient Placement Toolkit in 2015, and making sure that we get patients in the right level of care, and implementing and ensuring that we were following the 2 midnight rule appropriately. And so we looked there first because there was a lot of good work done at that time. We also reviewed the literature, and one of the good things about being a large health system is we got lots of experts. So we pull people together across the country and ask them about what's working in their organizations, what's not working, how can we be better, and what are actually, you can't change everything and we can't implement everything. So what are our standards going to look like going forward, and how are we going to get these accomplished across the country? So there was a lot of great dialogue, and this is what we came up with. So we have 5 utilization review excellence standards. We don't do more than 5 of anything, I guess, because there's 5 fingers on a hand, that, it gets too complicated. We'd love to do 20 things, but, it gets a little overwhelming and very difficult to be able to do. So what our 5 are is having a dedicated care coordinator resource in the emergency room 24/7. So having somebody in that emergency room, and I will tell you, when we surveyed our teams, we have from 0 to 24/7. So it is quite a variety of what we have. Some of them have, during the day, during the week. Some of them have 12-hour days that are covered. Some do weekends. Some don't do any weekends at all. So it's quite a variety. So we are in the process of ensuring that every one of our emergency rooms has 24 care coordinator coverage. Now, not every finance person wants to hear this. They don't want to give us all the FTEs that are needed. But we are working hard in showing the results and in ensuring that this is the right thing to do for our communities, to be able to make sure that we're doing the right work for them. So the second one is called a 3-way call, and it's actually between the ED physician, the attending, and the care coordinator for any patient who doesn't meet inpatient criteria following the case management review. So it's having the team have that conversation as to what level of care should the patient be going to. So we know everybody does not meet the 2 midnight rule, the MCG criteria, or the interqual criteria just as easily. And so we have those conversations to do our best to make sure that we're getting them in the right level of care the first time. We are standardizing our process for the initial review, for utilization review, that is starting when the patient is in the emergency room or whichever route that they come into the hospital. So our direct admits, our surgeries, all of that. And then we're having a standardized process for concurrent review and dedicated unit for our observation level of care. So I do understand that, there are different nuances, and I will tell you, the first hospital that I went to for these utilization review standards was in Fresno, California, and the first thing they told me is, California code, you can't have a dedicated observation unit, so we can't do this. So in reality, yes, there are things that are different in different places, but you can still cohort your observation patients to a few units and not have them in 12 units in the hospital, so that you can better provide their care, know they're in observation status, and initiate those tests and diagnostics that they need completed so that they can go. And of course, letting the patients know that they're in that observation level of care. So I'm going to go into each one of these just in a little more detail. So for our 24/7 care coordinator, they have priorities. Their very first priority in their work is to transition patients out of the ED to avoid unnecessary hospital stays. So I'll ask by a raise of hands, do you have an issue with patients going into observation who probably should have went home from the ER? Yes, many, many. So this is their first priority, is to make sure those that don't belong, and I'm not saying those that are clinically appropriate to stay and need observation care, or those that are clinically appropriate need inpatient admission. These are not the patients we're talking about. They're clinically stable. They're just complex. They have social issues. So how can we make sure that we're putting them back into the community? So some of the things that we do is we have a lot of value-based care. We have a lot of patients that are in the bundle payment for Care Improvement Advanced. We have a lot of patients in ACOs, and we also have contracts with some insurance companies in our regions to do value-based care, and we have risk with them. So with those patients, they all have resources out in the community. So in making sure to be able to identify them in the EMR, and I love the Epic shop, I love the Cerner shop. At Trinity, we have at least 6 different inpatient EMRs with multiple different versions of them, but we're also in transitioning and trying to get to a single medical record. And so I understand it in trying to do that, but in some of our EMRs, you can tell that in the emergency room that the patient's in an ACO, or they're in a bundle payment program, and to be able to do that. So what we are trying to work on with that is to make sure that they are going to be identified so that the ER care coordinator knows who to connect them with. So I will tell you, I had the pleasure of being in one of our hospitals in New York last week, and I was sitting in the emergency room, and I'll tell you, it was a beautiful emergency room that had just been redone, so everything was really nice and pretty. And the case manager in the ER was identifying patients that were there for ambulatory care sensitive conditions. So do your emergency rooms, are they working towards trying to not admit patients that have ambulatory care sensitive conditions? So in working on that, well, that is one of our priority strategic aims. So if the patients don't need to be hospitalized, that we should have done something different. How do we first prevent them from getting to the ER in the first place? And that's all the stuff we talked about yesterday afternoon and this morning. But then how do they, once they're in the emergency room, how do we handle that? So in having that, so they do have in many of our organizations access to the documentation of those other care coordinators out in the community and the ambulatory records. So with that they're looking and identifying those patients and connecting them back so that they don't have to stay at the hospital if it's not necessary, and ensuring that the ER physician is comfortable with sending the patient back to the community because those resources are available. And they actually do a warm handover to that ambulatory care manager, which is very, very awesome to see it actually happening. I know we talk about a lot of things, but it's nice to see when things are in place and that they're working. So that was a good thing to be able to see. So they're looking at that. And with some of our ACOs, they have the 3-day waiver program. So these ER care coordinators are also looking, oh, look, can we put them into a SNF this time? They were, that because they're eligible for a 3-day waiver, can we transition them right there? Now those do take a little longer, and I'll tell you, one of the things that the ER doesn't like is that they're not out in, an hour and a half or 2 hours. But in doing what's right for the patient and making sure that we are getting the patients where the appropriate level of care for them. So these are the things that they're doing, and they're also working with some of our frequent visitors, we call them, who frequently visit the ER, and identifying them. And there's a team that does complex care maps with them to identify how to work with this particular patient and what their needs are. So when they do come back, that they're doing that. And even going in and having conversations with the patient and family about the alternate levels of care they could come to if they really didn't need to go to the emergency room. So we're doing a lot of work with this in trying to ensure that the patients that we bring into the 4 walls past the ER are the ones that should appropriately be there. And so their second priority for these ED care coordinators is to apply screening criteria for the level of care, and based on payer requirements. So I will say, of course, with the Medicare population, we follow the 2 midnight rule. Some of our hospitals utilize MCG, some use Interqual, some use both, and use them depending on the payer in ensuring that we're utilizing that correctly. So in trying to do our best that when they are staying, to making sure that we get them in the appropriate level of care. So this process is what they're working on to make sure, and having those conversations. Of course, I know that it's not always easy. Everything's not back in the ER, and tough to do that. But in doing this, that we're making sure that we're working hard to do this. And when we did the survey, in asking our care management leaders, what do your teams do? So I said there was a very wide range of what those care coordinators, as far as the hours they work in the ER, what they do is another thing, as to huge variation. Some of them do nothing but transitions of care out. They never look at a case. They never have conversations about level of care. They are actually doing the inpatient assessment for care management that most of us think the care manager on the nursing unit would do. That they're doing those in the ER and then trying to transition patients out of the ER. In some of our other ERs, all they do is the UR piece. Nobody talks to anybody. I only go talk to a patient when they're out of network for their insurance company. So, that they're totally not, they want to hide in the closet and just do that UR piece. So trying to find that magic blend and trying to get the right people. So I know I heard earlier that, it doesn't matter what their credentials are necessarily if they have passion for what they're doing. So I think that in doing this, that as we transition our work to get our ERs up and running with the 24/7 care coordinators and doing the right things, that will have better outcomes. Just because you have somebody in the ER 24/7 doesn't mean that we're getting to the right things or having the right priorities. The other thing that they do is monitor the flow in the dedicated outpatient observation units after hours. So as we all know, that the observation patients are 24/7. So after hours, typically we have care coordinators in our observation units for 8 to 12 hours a day. So when they're not there, that the observation unit knows to call the ED care coordinator. The other thing they'll do is the observation care coordinator will do a handover to the ED care coordinator before they leave. Waiting on this test result, this doctor needs to see this patient just so that we know what's going on and what cases need to be followed up. And then developing plans for our frequent ED visitors. And this is done on a team basis, and we have several of them. They are called complex care maps. We have complex care map navigators in almost every one of our organizations, and have worked with the interprofessional teams to be able to do this. So I think that in doing that, it has helped decrease a lot of inappropriate ED visits in working with the patients where they are and understanding their needs and why they keep coming back. The three-way call. This one, I will say, some people are like, what? We have to do this? Why would we do this? So I think that it is extremely helpful for those cases that are in the gray zone. Not the ones we know are inpatient or definitely OBS, but the gray zone patients that we're looking. And so the three-way call is to happen with the care coordinator, the ED physician, and the admitting or attending physician. So we also have a wide range of hospitalist programs in our hospitals and also private physicians. So in trying to have that conversation, everybody has their piece of the conversation, right? The emergency room doctor has their eyes on the patient and sees what's happening. They're running the test. They know what's going on right at this moment. The attending or admitting physician a lot of times knows the patient, so they know what's happening elsewhere, right? Oh, the family has a great support system, or they don't. What has happened, what has worked before, what hasn't worked before, to be able to input into that conversation. And then the care coordinator who has the resources in the community that they know, or within our own organization, if they have an ambulatory care coordinator or anything else that's available, that they're making sure that that all happens. So having the three of them on the phone together to make that determination is extremely helpful. So what we have is to put that together and then the conversation that they have. And then we have put in there that the ED physician is the one who documents the call in the EMR. And the reason for that, or their scribe, and the reason for that is because we need that physician documentation in supporting the admission instead of somebody, the care coordinator, just writing in their UR section, you know, we talked and this is what happened, that the actual information, and those are the critical decision-making points that are made to determine what level of care the patient needs to go to. And so I think that this is, now you'll probably believe this, that they don't all agree. So even at the end of the call, we all may not be in agreement. And absolutely the end decision is the physician who's admitting the patient. It's their decision. So if the patient's not meeting the criteria and the care coordinator feels like that's not the appropriate level of care, they pull into, the patient gets to the level of care the admitting physician wants, and then they do a referral to our physician advisor. And the physician advisor is pulled into the case to be able to follow up and ensure whether that is the appropriate level or what needs to be done and how things go after that. So the other thing that we've asked in this, because the care coordinator doesn't need to be on this call except when there's discrepancies. So if there's a case where the ER physician calls the admitting physician and then there's a discrepancy between the two of them, we ask them that they pull the care coordinator into that call. So, and I'll tell you, there was something I saw last week when I was at one of our hospitals in New York that I thought was just great, that it was the newer ER, and they called it the fishbowl. So there was this glass room with all glass walls around it, and in that room sat the admitting hospitalist, the care coordinator, and the social worker. So they were all in the same room and it was all glass walls around them. But when the ER physician felt a patient needed to stay at the hospital, they walked in there and they presented their case. So they had the three-way call on every patient. Now that is not what we're requiring, but I thought, wow, this is very interesting as to how can you do this and how easy it was that then we have agreement as to every patient that's staying at the hospital. So I think that was really a good thing to be able to do. And most of our ERs aren't like that, because I went the very next day to another hospital. The case manager sat in the middle of the ER. It was utter chaos and all kinds of patients in the hallway and everything. Nobody talked to them. And it was like, and they said, and what they told me is, you know, I wish we were in a better spot. I says, well, where is the better spot? Because to me, you're right in the mainstream of everything. And they said, they didn't know. So there's just really some communication issues and that in that ER that needs to be done to be able to understand what their roles are. The next one is the initial review process. So we want consistent initial reviews, okay? The health plans want the information that they need to be able to, you know, authorize the stay for us in those times when we need authorization. So we want to make sure that this is happening, and of course it's dependent on the insurance that the patient has, whether they're using Interqual MCG or the 2 midnight rule. So I think that in doing this, this is something that's been done forever, but in doing this, it's also has changed over time. You know, when I was first a case manager, we were on the phone with the payers, on hold, doing all those things, giving all that information and getting our authorization. Now we send them stuff electronically, and boy, I surely wouldn't want to be on the receiving end of a lot of that, because I think we send them pages and pages and pages of stuff for them to sift through and figure out. But they want everything, and they guess they just don't want to go on the word of somebody saying they have a low hemoglobin, you have to send the lab value, or they have this history, they want the H&P. So I think part of it is a burden on both sides as to all of the information, but we have to really build in trusting relationships and learn to work together so that we each trust each other and are able to go forward with getting authorizations and being able to do this and ensuring that our process is hardwired so that they're not just admitting everybody just because. It's that they meet the criteria that they're supposed to meet, and if not, that those cases are elevated to a physician advisor to then be able to intervene and make determinations as to what needs to be done. This starts with our registration folks in the emergency room, right, to make sure that they're asking for patients' insurance, that they're doing their best to get the accurate insurance, and that the insurance is verified, and the payers are notified so that the case managers can send that clinical. So I think that we're working on ensuring that the process is the same and that they know when to refer to the physician advisor. So across our system, we have internal physician advisors, we have remote physician advisors, we have external physician advisors. So it's quite a lot different, but they should know their own process in their organization to be able to do this. So once all the initial piece is done, the concurrent review, right? So afterwards, we're waiting on authorization. I think some of our hospitals feel like that we don't get authorization until the patient's discharged so that they can see if they go home quick to see if those cases can be denied or changed to observation. And then following them concurrently to make sure that we're getting them out in time. And so I know we've heard people talk about discharging. We use the word transition. We don't want to discharge anybody. We want to transition them to the next level, whether it be their primary care physician, whether it be home care. We want to keep them within our system. And I think everybody's been talking about wrapping their arms around them. That's what we would like to do also. So in making sure that we're doing this timely. So upon admission, that we are making sure that based on the information that we have right now, what is their estimated data transition? And so, we're using this off of the GMLOS based off of the information that we have, and we're talking to the patients and families, their first day in the hospital as to, this is when we expect you to be transitioned out. So, and so there's no surprises, right, in making sure that we're doing this. And then we call them interprofessional rounds. We've talked about interdisciplinary rounds. We have interprofessional rounds on all of our inpatient units. And so this is to drive the throughput also, identify barriers to transitioning them out, or figuring out what the plan is. So at the last day, we're not all, okay, so now what do we got to do to get this together? That we're planning it right from the beginning and ensuring that we are prepared for them to be able to be transitioned out. So I will say that something that surprised me, because I've presented these to several departments within our organization, but we call them payer strategies and product development. Most of you call them contracting. They like this. They like this. They want us to get this hardwired across our system so they can use this in negotiations for contracting. So they're hoping that we can get this put together so that this can be used, that this is what we do consistently. We consistently review every patient when they come in. This is the process how they get approved. This is what we do when there are those gray cases where we have to get a physician advisor brought into the case, and this is what our process is. So they're hoping that this will help them with that to be able to get us better reimbursement rates, because we are showing what we're doing. And then the last one is the observation level of care. So we would like everybody to have a dedicated observation unit where possible, and if not, cohort those patients in the minimal number of units that you can, making sure that the patients know that they're in a observation status, because many think that they're up in a hospital room, that that they're inpatient and don't understand the rush to get out, or the testing that needs to be done, or what can be done within the hospital or out of the hospital. So in looking at that, many of our hospitals do have dedicated observation units. I haven't found one that doesn't have patients also in inpatient units, because the observation units just aren't the size that for the volume of observation patients that they have. Now on the flip side, we don't want to build a 100-bed observation unit, because you build it, they will come, so we don't want that many. But it's trying to find that balance and making sure that they are. Some of the things that we have identified is that they are They put what I call all the easy patients in the dedicated observation unit. They have better outcomes. They get out sooner. They have shorter lengths of stay. They have all these good things. And all the complex ones go up on the medical floors with the complex medical patients and think they're inpatient. So I think that we have to kind of look at that and in determining which patients we need to put in those units and how to better manage them. Because we have such a variety of providers, our recommendation is having advanced practice providers caring for these patients 24/7 with oversight from a hospitalist as available. So we do have some hospitals that are almost all still private physicians. Those are quite difficult to manage a length of stay in an OBS unit if they only come into the hospital once a day, and then trying to follow that up. So trying to figure out how we can get a better handle on that and getting those patients served better, quicker, more efficiently, and making sure that we're doing that. So I think that we would love all of our OBS patients to be there 23 hours or less. Unfortunately, not everybody is in agreement with us, and part of it is our own throughput issues. You know, you have to have testing available, you have to have diagnostics. I was at another one of our hospitals a few weeks ago, and echoes, right? We do way too many echoes, and then getting echoes read timely with, to get all of that done, it's quite difficult. So I think that we have, those opportunities to become more efficient, to pull in our process excellent people to help us to be able to do throughput better. So I think there's a lot of things that we can do on our side to be able to help. And in some of our EMRs, I think there's good communication and good handover tools that we are communicating with our care coordinators that are on the outpatient side. So I was at one of our hospitals about 6 months ago, and I went and I was shadowing. I love to shadow the frontline staff. They're my favorite. They do all the hard work, and you really see what works and what doesn't work. I was shadowing a case manager, and she was able to see that her patient came in and she was going in to do the assessment. So we looked in the EMR, and the case manager on the ambulatory side had wrote this beautiful note in her. She knew her patient was going to the ER, and this is what happened, and this is what we got in place, and don't do this, but do this, and let me know. So, I mean, we're getting there. We're not there everywhere, but I think that there are a lot of things to be able to communicate and do that. So I think it's great to be able to have those conversations and be able to do those handovers. And we don't call them handoffs, we call them handovers, because we just goes everywhere. And we need to do it to all levels of care and to be able to do that. So in implementing this across the health system, it's not easy. I'll start with that. Education, education, education. I heard somebody say, well, you educate 25 times and then you start education. So I think that it's not easy. So what we have done thus far is for the first 4 standards, we have done short recordings. So I want to say the longest one is 10 minutes maybe a little longer. The shortest one's less than 5 minutes. So we did one separate for each standard so that those individuals that utilize that could do it. So I'm going to go back to the 3-way call really quickly because it's less than 5 minutes. There's a written out guide with all those answering. All right, look. There we go. Technology, gotta love it. So there is a written guide for each one answering all those questions, what to do, who does it, all of that good stuff. And then we have a recording for each one, and they're short. So it's a verbalized, but in there also they could print out the transcription for those that are visual learners. So trying to hit all the different learners. But for that one, I want all of our ER physicians to to listen to that. So I don't want to give them a half an hour education session, 5 minutes or less, and to be able to do that. Whether they do that at an ER physician meeting or they email it, because it's just a link for them to be able to go in there and do that. So I think that we need to make sure we're educating the right people and being able to hit the gamut across there for that. So I think that what we've done is tried to do this and get them going. So myself and one of my colleagues, Kathy, are responsible for, I think we're going to 39 of our hospitals in a short period of time. So we're on the road right now. But what we're going there for is to see, do they have barriers, where are they at? So I will tell you, the first hospital we went to was Fresno, and they hadn't even been released 10 days. And we knew this, and we warned them, and we sent them stuff ahead of time. But if so, they weren't there yet. But when I'm in June going to one of the other hospitals, I hope that they have all of this implemented and it's all going well, so that we can just observe and help them with any barriers, right? We don't want them to wait for us to come see them to start the work. We want the work done now. So I think with that, and then we also use the American Case Management Association COMPASS modules for our care management education on the acute care side, and so we have required some of those modules for this work. We asked everybody to complete a gap analysis. So this was a twofold gap analysis. One, it was for the hospitals to look at and see where they are as compared to the standards. The other is because people are always asking me, okay, so who else like us does this, or who does this like this? So we are doing what I would call an inventory of our hospitals, because it's very difficult to try and pull information as to what their care management model is, what their payer mix model is, how are they doing it, how many hours, how many FTEs versus how many staffed beds, so all of these things. So we're gathering so that we can share. Because one of the gifts that I think that I have in serving Trinity Health in our communities is I get to share with people. I get to go to one place and learn stuff, and then at the next place I could say, oh, well, you could do this, contact this person, and you can do this. Those at the hospital don't get to do that. They work in their own organization, and they don't have the gift of being able to do that. So I do spend a lot of time trying to connect people and the work. So I think that was really helpful. So data. So I'm still in the process of getting the analytics people to build my dashboard for this, but we do have data. And so we are looking at readmissions, right, as to one of the things that has been a hot topic here. We are looking at our operational write-offs, our observations. How many patients are we downgrading after they come in because they inappropriately were placed in inpatient? Or how many patients are we going from observation to inpatient? Has that changed since before we implemented the standards? So I think that we're doing that. And then the site visit, like I said, my friend Kathy and I are going to 39 of our hospitals to get that done. So with that, okay, so all right, now it won't move. Isn't that funny? So the last slide is just questions. So does anybody have any questions for me? Yes. And I know lunch is after this, so this is, like Bridget said yesterday, she was between cocktails, okay? I got from here to lunch.
Thank you for that presentation. I'm Leslie Marshburn from Grady Health System here in Atlanta. You talked about trying to prevent your frequent ED patients from being admitted. And you mentioned a care map, a complex care map. Can you talk a little bit about what is included in that, and then what the credentials are of your complex care managers? I assume they work with that population.
So we, actually,
okay,
probably not. We all use a lot of terms, care coordinator, case manager, navigator, all those. So I will say each one of our organizations, I believe currently has, unless for some reason they've left and are switching, but we have a complex care coordinator, and their whole job is the complex care maps in those patients. So they do a deep dive into what's been happening with that patient for like the last 5 years, okay? They go back and do a lot of research, they pull information, and they're able to identify, they meet with the patient, They also meet with the care team. So, everybody that goes in and has worked with the patients, they pull together. They try to pull in also their primary care physician as appropriate, right? So as to see what's else is going on outside the community, and pull all of that together so that they have a care map. So this really is, and the whole social piece, they have social workers that help them, case managers. And the whole idea is to be able to work with these patients, to help them in this. It is not what you would call a longitudinal care map, okay? It is not a health, it's not the clinical plan. It's how else do we work with them? How to identify, oh, did you try, when they come in, oh, last time you agreed that you would try this first, you know what I mean? You would call your doctor, you would call your case manager, you would do this, and seeing and following up. So it was actually started out of our hospital in Grand Rapids a few years ago, and so that it has evolved and we've spread it, and it has really helped decrease ER visits on patients who don't need to come there. So they meet, and I can't say they meet at least monthly as a team, as a care team, and they review complex care maps, and then they pull in and set up conversations. It is not something that's happening while the patient's in the ER.
Hi, great presentation. My name is Vanessa Rochelle-Stacks from Rush University Medical Center in Chicago. I have a couple questions. First, have you implemented the three-way call? I love that. I'm intrigued by that in an academic medical center, and just curious around the receptiveness of some of the teaching teams with the three-way call, if you have. That's my first question. And then as a second question, have you seen any impact on your observation rate as a result of some of the changes that you've been able to implement with the redesign, and what are you seeing in terms of observation rate across your system?
So lots of questions. So I would say, as far as large academic centers, the only one that is ours is Loyola, which is just outside of Chicago. And so I will tell you, I don't know where they're at today, but I was at Loyola last April, May. And at that time, their care coordinators in the ER were just doing transitions of care. They were doing no UR. So they're in the process of implementing this part. So I could say that. As far as our other hospitals, in looking at pulling in the teaching team for the three-way call, I would say I would have to survey to ask if they're doing that, but if that is who is admitting the patient, by all means, if that's the accepting person, I would assume that that is who they're having that conversation with in doing that, because I think that, yes, we do need to do that. I will tell you that at our interprofessional rounds, there are many residents that are speaking about their patients. So I think that we've done that. As far as observation, I will tell you that because we've only got this actually rolled out within the last few months, we really don't have the observation data yet, and we didn't ask them all to go build new units at this point, right? We want to cohort them. We want to prove that this works. And actually, one of the articles I read, and I wish I could remember the physician's name, was from Rush about a dedicated observation unit that I used as one of our resources in pulling this information together. Yeah, and I wish I could remember his name, but sorry. All right, well, I will just say thank you, and where do they go?
Yeah, thank you. Can you hear me? Okay, thank you very much, Colleen. That was amazing. Thank you.